Dear friends, let's start these chapters summarizing my concept on retinal detachment with an attempt to explain the pathogenesis of rhegmatogenous detachments. I said detachments because there are two types of detachment: retinogenic detachment and vitreogenic detachment. Between 15 to 20% first procedure rhegmatogenous retinal detachment, 20% in my statistics, occur in the absence of vitreous traction. This is why I call them retinogenic. It is in this category of detachments that we find the detachment by trophic hole. As seen in Chapter 9 of my playlist on macular surgery, these trophic holes, whether macular or equatorial, are probably due to choroidal ischemia in watershed zones. A small amount of liquid coming from a vitreous lacuna, bursae premacularis for the macular hole, or equatorial bursae of Wurst for the equatorial holes, will gradually enter into the hole and be pumped by the pigment epithelium. If the epithelial pump is not sufficiently active, as in the case of eye myopia or at the level of lattice degeneration, the liquid will very slowly detach the retina without any vitreous action, if we accept the tamponade action of the vitreous. It is also in this category that we find detachment by retinal dialysis at the ora serrata. Whether it is post-traumatic, more often nasal superior, or idiopathic temporal inferior, and that must be opposed to giant tears, which are of course due to a vitreous traction. One can also include in this category the detachments by optic pit, for which the vitreous does not play a big role except once again a role of tamponade. The fact that in the case of retinogenic detachments, the vitreous continues to tamponade the retina and that only a small amount of liquid penetrates through the dehiscence explains why these are low-progressing detachments. The transparent, microcystic appearance is suggestive of these retinogenic detachments. The age of the detachment is sometimes such that new vessels of ischemic origin may appear. Fluid sometimes enters the retina so much that intraretinal cysts can even occur. In addition to their transparent pseudoschisic aspect, these slowly progressive detachments are marked by subretinal progression lines showing the different stages of their extension. Sometimes, when the progression is extremely slow, this progression line, a real attempt of self-limit the progression, give the appearance of photocoagulation impacts. In the vast majority of cases of this retinal detachment, there is no PVD. This explains, as we have seen, that the vitreous limits the progression of the detachment, but also that the pigment epithelium stimulated by the RPGF does not pass into the vitreous cavity, and that therefore most of the time the operator does not see any pigmentary tendril. This is why in 1985 I invented the stage 0, just designing these detachments without any stage of PVR and without even pigmentary tendril. Let us now refer to my study on primary procedure detachments and consider the stage distribution of these detachments. If we look at how these retinogenic detachments are distributed, what can we see? The detachments linked to equatorial holes are not all stage 0. There is roughly 15% stage A and even 3% stage C1. Same thing for macular hole detachment, even if the number of stage A and C1 decreases. As for detachment by dialysis, a small number are found in stage A. Why? Because dehiscence has occurred in the absence of vitreous traction, that vitreous detachment cannot occur either before or after. And if the pigment epithelium does not pass through the majority of trophic holes or dialysis, it is simply because in the majority of cases the vitreous is not detached and prevent it from doing so. It is moreover in these cases of retinogenic detachments that one can observe what I call two stages detachment, where we see a first zone detached from the vicinity of a dehiscence, transparent, pseudoschisic, sometimes delimited by a progression line separating it from a more traditional detachment zone lower than the first zone. For quite a long time, the detachment was limited to the first zone, and after the PVD, it abruptly extended since it was not buffered by the vitreous. We can immediately see the complexity of things, even in the simplest cases where the dehiscence which causes the detachment is not generated by vitreous traction. It can still develop PVR depending on whether the vitreous is detached or not. We already understand the advantage of being able to locate the posterior haloid. 80% of retinogenous detachments are caused by retinal tears following a vitreous traction during the PVD. That's why I call them vitreogenic. These vitreous tractions are done at the level of vitreoretinal adhesions. There are two kinds of tractions, dynamic or static. First of all, dynamic tractions. They are retrobasal, most often close to the equator, and often in relation to areas of retinal thinning, such as lattice. If you saw Chapter 9 of my macular surgery playlist, I suggested that these tears are caused by a choroidal ischemia linked to a circulatory problem in the area of choroidal watershed zones between the short posterior ciliary arteries and the recurrent anterior ciliary arteries. The ciliary ischemia would lead to two things: a retinal thinning, but also an astrocytic proliferation in response to hypoxia. This proliferation would enter the posterior haloid fibers, producing adhesion, and during the PVD, traction on these adhesions, leading a tearing of the thinned retina. This is why, when the tears are related to a lattice, they are located on the posterior edge of the lattice. Anyway, the vitreous traction can be either discrete, barely visible, or stretched like a cord inserted in the flap of the tear. It can even tear off the flap, simulating a hole, but the existence of the flap and the adhesion of the vitreous around the tear, highlighted by dynamic maneuvers, prove that it is a detachment by vitreous traction. There is another location of dynamic traction. It is at the level of the vessels of the posterior pole, generating tears called paravascular tears, or more rarely on the edge of the papilla. This is mainly seen on high myopia. The detachments created by these posterior tears are of poor prognosis. Now the statice traction. They are located on the posterior part of the vitreous base. The anterior edge of the tear is fixed by the vitreous base insertion. The posterior edge is mobile. We can clearly see in this example vitreous fibrils on the fixed anterior edge of the tear and the posterior edge moving with the movements of the globe. But whatever the traction style, static or dynamic, the retrovitreous liquid will be able to enter through the tear and cause a detachment with, as corollary, a stimulation of the EGFR and therefore of the RPGF. The pigment epithelium will therefore proliferate. It will dedifferentiate immediately into fibroblast and myofibroblast, having a contractile power and being able to create subretinal membranes. But it will specially go through the tear to form a pigmentary tendal, which will mark stage A. To continue to proliferate, the myofibroblasts must fix themselves on two surfaces of vitreous collagen. First of all, on the posterior surface of the vitreous, and gradually the myofibroblast contraction will create a contraction of the vitreous base. To understand this phenomenon, you must imagine the vitreous pancake adhering to the retina by its base. The contraction of the pancake will move the retina away from the pigment epithelium at the base level. This distance can be significant even for a slight contraction. Example, if you remove 1 meter from a 40,000 kilometers rope surrounding the equator, the Earth equator, it will cause it to enter 16 centimeters into the ground all around the equatorial periphery. This is why even at the beginning of contraction of the vitreous base, we can see a small circumferential fold, and this small fold can be seen even in apparently simple cases. But the myofibroblasts can also fix themselves on posterior haloid plaques abandoned on the retina by the PVD. We have indeed seen in the macular playlist that it is not because there is a PVD that there are not here or there plaques of adherent hyaloid, either fixed by a glial proliferation or embryologically nested in the inner layers of the retina. If there is a hyaloid plaque just behind the tear, the contraction of the adherent hyaloid fibers under the effect of myofibroblast will reverse and fix the posterior edge of the tear, and we will have the characteristics of stage B, which may be accompanied by clumping of peripheral pigment. Finally, whether behind the tear or on other adherent hyaloid plaques, the formation of contractile membrane will give rise to these retinal folds and PVR nodes characteristic of stage C. We understand immediately how intraoperative removal of this hyaloid plaque can have a preventive effect on postoperative PVR. So everything looks simple and clear when you say it like that, but in reality everything is not that simple. For example, let's look at the stage distribution according to the type of tear as we did for retinogenic detachments. Small tears located on the posterior edge of the lentis or on the posterior edge of the vitreous base are mainly found in stage A, but 7 to 8% are also found in stage 0. The same goes for detachment where the biggest tear is a medium-sized tear, and which in almost 5% of cases do not show a pigmentary tendril. One can even find in this vitreogenic group detachments in 2 times, as in retinogenic group. Why does the pigment epithelium not pass into the vitreous in some cases? I don't have the answer. On the other hand, as you can see, in 25% of cases due to a medium-sized tear, the pigment has proliferated on hyaloid plaques, causing either stage B or stage C. When the detachment is due to a 1-quadrant large tear or a giant tear, the rate of stage B increases considerably. Finally, when the detachment is due to a paravascular tear in the posterior pole, the percentage of stage C is double that found in the event of a large tear or a giant tear. I tried to establish a severity index for each type of dehiscence. For this, I calculated the average failure or silicone oil injection that we could be entitled to expect according to the PVR distribution and counter for each retinal break. We can thus see more visually that the risk of failure in dialysis is practically 0, and that the risk of failure in paravascular tear is at the same level as that of a large or giant tear, that is to say, 30 times higher than that of dialysis. Why do vascular tears give a detachment such a sad prognosis? To try to understand what happened during a retinal detachment, I did in 1985 and 1988 a huge prospective study of nearly 1,000 detachments using the Kowa laser self-flare meter. This device is an instrument that can objectively quantify in the antechamber of the eye the flare, that is to say the protein concentration reflecting blood-aqueous barrier breakdown, and the number of inflammatory cells, histiocyte or macrophage. At the time, patients were staying 6 days in the clinic after operation. The measurements, 5 per session, were made the day before operation, the following 6 days, and after 3 weeks during the control, which makes a total of 40,000 measurements that I presented to the Gonnas Club in 1990. And nobody understood a word of what I said. I will try to be clearer. First of all, know that a normal subject has a flare rate around 5 and has 0 cells in the antechamber. In a standard detachment, the protein concentration which contributes to the PVR developments is higher the day before the operation and increases after the operation to reach a peak on D3. The inflammatory cells present the day before the operation tend to disappear more quickly. Flare and cell level are higher in pseudophakic detachments and in the case of previous surgery, which seems normal. They are also higher in case of hypotonia. Here are the curves depending on whether the pressure is higher or lower than 8. We have all learned that the pejorative effect of a large hypotonia in the prognosis of the detachment, but here we have an objective demonstration. The curve also depends on the PVR level. Here is a series of phakic eye with primary intention with a pressure higher than 8. The detachment on stage 0 do not show increased figures compared to normal. Stage A detachment are twice compared to normal, and stage B and C1 detachment show figures 5 times higher. If we finally study according to the type of tear on phakic eyes, primary procedure with normal pressure, and all of stage A, we can confirm what we did not understand. The curves, when the detachment is associated with the paravascular tear, even if it is very small, are as high as when there is a giant tear. But we can even go further in the study by selecting, for example, the phakic patients with normal pressure, primary procedure, stage A, and presenting only small tears. We can then compare 23 cases with a single tear associated with a single detached quadrant versus 20 cases where small tears are associated with 2 detached quadrants. The flare and cell curves are different. The laser cell flare method, therefore, allows us to compare very precisely correlated curves with very specific clinical cases. If now, and we arrive at the most interesting part of the study, we compare retrospectively the curves obtained with the curves that we could have expected due to the precise clinical cases, we can see that in 88% of the cases, the curves obtained are in conformity with the expected curves. In these cases, the recurrence rate of the detachment is around 7%. But in 12% of the cases, the flare or cell level are completely absurd without any reason. As here in this primary procedure phakic case, without hypotonia, stage A, where the flare curve is comparable to that of a stage C2. In these cases, the recurrence rate is 40%, and no clinical details allowed me to understand why. So you can see that there are still some gray areas. Personally, I think that we underestimate the role of vitreous attachments to the retina, but I cannot prove it. These studies with laser cell flare meter should be repeated, as you will see in the strategic advice of the Vitreous RD study. In fact, all the cases where statistically it seemed advisable to perform a vitrectomy are very exactly the cases where the rates of flare and cell are high. There is certainly something to search in this area. Systematic measurement the day before the operation could make it possible to determine precisely who are the patients for whom it is necessary to take the risk of complication linked to the vitrectomy, and which are those for whom it is better to treat by buckling. In the next chapter, we will talk about the incredible results provided by the Vitreous RD study.